Just have to make sure I know how to use this. Okay. Well, it's great to be back in Vietnam after 2 years. I'll just get right moving to it. I'm going to talk about super large bore catheters and various modes of flow arrest. So we know that aspiration capacity increases with catheter ID. And so over the past 2 decades, there's been a consistent trend to developing large bore catheters, what Blaise Baxter referred to yesterday as larger straws. So I'm certainly old enough to have ridden this train from microcatheters and TPA. So 2007 is easy for me to remember that we were playing around with catheters with IDs of 026 to 041, and now we routinely use large bore catheters of 070 to 074. We also know that maximizing, I guess I haven't learned how to use this. There we go. Maximizing or matching the catheter diameter to the vessel diameter likely enables us to exert significant local flow control regional to the clot. And with the arrival of super large bore catheters, so catheters that are 088 diameter, not only potentially achieving flow arrest at the site of the occlusion, but we see flow reversal distal to the occlusion, and the thought that those two features, flow arrest and flow reversal distal to the lesion, likely enables or will help us achieve full clot ingestion while reducing distal emboli. And that led to this idea of a technique called SLIC, super large bore ingestion of clot, where placing a right-sized catheter to the vessel proximal or at the face of the clot and not necessarily crossing the clot, that we could entirely engulf the embolus and evacuate it. And again, potentially negating any distal emboli. Before these super large bore catheters were approved for us, there's a system that had an 088 guide catheter, the Zoom system by Imperative. And we were using that, and it didn't take long for people to realize that you could take that Zoom 88 guide catheter that wasn't FDA approved to go into the intracranial circulation, but we were routinely getting it to the intracranial circulation. Imperative started a trial which we enrolled in, and we were encouraged to take this super large bore guide catheter and try and treat ICA and MCA occlusions. The trial has since ended, but this is pretty much how we were doing the cases using the super large bore catheter. So the first thing that I typically did was put a sheath in the carotid. And this is almost an admission that super large bore ingestion of clot doesn't always work. Because the reason why I would have what I call a carotid placeholder is in case I didn't ingest the clot and I had a piece of clot corked on the catheter or a distal emboli, and I've got to go back in and make a second pass. And so having this carotid placeholder to go and do additional passes, to me, was a critical thing. I was already putting a sheath in, so why not put a long sheath in and have your carotid placeholder? So through the sheath, we perform an arteriogram, and here you can see an M1 cutoff, occlusion. So through, and this is an 880 shuttle, so this is the shuttle that's within the carotid, and we use this triaxial system of Zoom 88, 71, and Zoom 35. So don't get caught up in the names, just basically the Zoom 88, that's our super large bore, this is our large bore, and then a smaller distal access catheter. This is the company that makes that Colossus wire I was talking about. So this was a much bigger wire than we were traditionally using, like an 04 wire. So 24 wire, much more support very, very talkable and atraumatic, approved for the intracranial circulation. And you can see this kind of really minimizes the ledge effect that you have because of the wider diameter of the wire. And so that construct enabled us to ultimately, in most cases, deliver the super large bore to the occlusion. The first step is though getting the large bore to occlusion, and I typically intentionally do not try and cross the clot. I really don't want to interact with it and potentially fragment. So typically I would put the large bore catheter at the face of the clot and initiate aspiration, and then almost using that as an anchor, like you would a stent retriever, advance the super large bore catheter over the large bore catheter. And so once we get our large bore catheter to the face of the clot, the super large bore catheter, the large bore catheter has grabbed onto the tail of the clot. And so you bring it back and essentially relay the face of the clot into the large bore, which is now at the face of the thrombus. Okay, so grab the tail with the large bore and relay the clot into the super large bore. The large bore comes out and you maintain aspiration through the super large bore at the face of the clot, and you can really see the right size matching between the the diameter of the super large bore and the MCA, and getting that feeling like, okay, I may have flow arrest and potentially the benefits of retrograde flow reversal. So if you're, sometimes you may get ingestion right there. You turn it on and you ingest the clot, but it doesn't always happen. You can't cork the clot, and again, that's why I like having the shuttle in. If I'm taking clot out, right, because it's corked, if this was the only guide catheter I had, I would have to re-access the carotid. So if there is a distal emboli or there's remnant clot at the site of the occlusion, I can go back in with my shuttle. What I find is that if I'm corked, and you know this because you're not seeing blood coming through your tubing, you slowly pull the super large bore back, and I let it sit in the carotid terminus for about a minute or two. Blaise Baxter taught me that. If you let it sit there and it's well corked, having the flow around the catheter, typically, almost always, it'll suddenly give, and you have that tactile sensation of blood coming through the catheter. And if you look at your tubing, you can sometimes see this darker thrombus come out, and then you know that you have it. And it's pretty routine that you see just clean, smooth revascularization with TICI-3 flow. So that was an off-label use of a super large bore device. Recently, in the US and maybe a European country or two, there's been approval of Route 92's monopoint reperfusion system. So this is a triaxial assembly. You've got a base cam guide catheter, an 088 high point catheter extender, and this is an interesting catheter. It's a catheter on a stick. And so it's a short segment of catheter. It minimizes your catheter-catheter friction, and the proximal hole is really inside the base cam catheter, and it's sealed so that when you do your aspiration, you actually aspirate through just a single monopoint via the guide catheter. This is called a TENSing device. It's an insert catheter, tapered, very soft, atraumatic. So this is the whole telescopic assembly put together, and this tapered telescopic assembly minimizes ledge effects, so you're not catching onto, PCOM, ophthalmic. You can ride this up pretty efficiently and atraumatically, seeking out your ICA or MCA target lesion. And again, you can see that the system is simplified because there's just a single hemostatic valve monopoint that you're advancing your system through and aspirating from. So here you can see the TENSing going up pretty quickly with the aspiration catheter behind it. Tensing reaches the clot. Super large bores advance to the face of the clot, and the tensing insert catheter is removed. And again, here you can see that the tensing has been removed. This is just the stick of the catheter, and the entire catheter is housed in the base cam guide catheter and sealed, so that when you hook up aspiration, you're just simply aspirating via the guide catheter. The catheter is sealed distally, so you end up effectively just aspirating through the proximal lumen of your super large bore catheter. But this is life. I've been doing this many, many years. It's a great technique, but it doesn't always work. Carotid T lesion, thrombus extending into the right A1 and MCA, a right-sized super large bore catheter. This is the Zoom 88, interacting with the face of the thrombus, revascularized MCA territory, and a big fat embolus that I now have to chase into the anterior cerebral. MCA occlusion, right-sized 088 super large bore catheter, open up the MCA, big wedge defect with a distal occlusion that I'm now chasing. It works well, but it doesn't work all the time. So, what to do? Keep on going. I kind of took this little journey where I walked backwards to go forwards. We've had balloon guide catheters, occlusion balloons, for a while. Why did we use them? Well, with a plug and pull technique, the tip retention force is the only thing that's holding onto that clot. And it doesn't take much to have this sucker leave your catheter and embolize to new territory. So with the balloon guide occlusion, having that proximal flow arrest is thought to limit fragmentation and embolize to new territory. Additionally, the flow arrest creates flow reversal. So through leptomeningeals, right, we now get reversal of flow that potentially facilitates ingestion of the clot. But there was resistance to use this technique because the earlier generations of these balloon guide catheters were very bulky. There could be difficulty with arch navigation, potentially traumatic to the internal carotid artery. And you know, there was a degree of resistance to utilizing these catheters, but now we have newer generation balloon guides. I've been exposed and playing a lot with the Capel Walrus balloon guide catheter, and this has variable stiffness with a lot of proximal support. It's got good distal flexibility, and the large ID really accommodates any of our large bore catheters. So some key features that I find, and many do, of the Walrus guide. Here you can see an acutely angulated origin of the right internal carotid artery. It's hooked with the reverse curve catheter. Wire is going up into the ICA, and you can see it's not really straightening that reverse curve catheter much. This does not seem to be a problem for Walrus, that it easily navigates these acute turns where you can reliably deliver the balloon guide catheter into the cervical internal carotid with pretty horrible arches. The other thing is the ease of distal positioning, and I promote distal positioning for any guide catheter that you're using, really. But I aim for the petrocavernous segment, and almost always you'll be able to get it there. And this achieves optimal thrombus control. Basically, very short pullback distance for that clot because your balloon guide is so high. You're also decreasing the distance that your balloon guide is going to aspirate potential debris in the internal carotid. And again, should you need to make a second pass at the lesion or there be an embolus, that you've maintained high access to quickly run up and get to your target. This is my current setup, 8-French femoral sheath, you are going to feel this tightness putting the guide catheter through the sheath, but it's going to work. It is going to work. I used to have a very low resistance with elderly patients, severe aortoiliac tortuosity, to use a 25 centimeter 8 French sheath. Don't do that here. You're going to fight, you're going to potentially rupture the balloon. It'll go through a short femoral sheath, but it is a real battle putting this through a 25 centimeter sheath. I would almost always use a Simmons, even in a young patient. You know, you often think a young patient, you're going to quickly hook the carotid. That left carotid can be a bit of a bear where the catheter just keeps on bouncing from the right carotid to the vertebral. But it's really easy to hook a Simmons into any of these vessels. And again, keep in mind, you really don't have to advance the Simmons. The walrus will almost always just go up with a wire through a Simmons, even in tortuous anatomy. If you're really concerned about bad anatomy, you know, a bad type 3 or 4 arch, I do a lot of radial work. I don't know if you've used the wrist catheter. It's really a radial catheter, but it's long, and it's stiffer than the one that I typically use, the Penumbra Neuro Simmons 2. So if you've got like a type 4 arch, really acutely angulated, I would use the wrist Simmons 2 because it's just got a stiffer nose and is more likely to support advancement of the guide catheter. The aspiration catheters, I've been using the Zoom system for a while, so I maintain my use of the Zoom 71. It's got a beveled edge, very good aspiration capacity. And I've recently moved to a Vector 46, and I'll show you an example why. Essentially, it comes down to a good match between ID, but importantly, length. This is a 160 centimeter aspiration catheter. And then this is the same company that I mentioned before. Now fairly routinely using this Colossus 035 wire. It is approved for the neurovascular circulation. It's 035, a lot of support, very atraumatic, and highly, highly, highly torqueable. This is a Colossus actually through an 058, minimizing ledge effect. So this ledge effect is even going to be less with a Vector 46. So just go through a technique summary. Actually, when this case came in, I was sitting with, I'm shining the laser at you. I was sitting with Blaze. He was at my shop, and 31-year-old, history of neurofibromatosis type 1 with a nerve sheath tumor that had been operated on. It was recurrent. Presented with, at an outside hospital, profuse tracheostomy, bleeding, shock. She underwent a PEA arrest, and was resuscitated and transferred to our facility. Not too many years ago, I would have gotten this phone call, but they called vascular surgery, who took her to their angio suite. They were worried about a tracheocarotid fistula. This is the CT that was done. No bleed was seen. You can see tumor partially encasing the carotid, and you can see this linear filling defect within the carotid. The vascular surgeon did an arteriogram, did not see any bleeding, was concerned that this was a dissection, and thought he would put a stent graft in, selected the carotid, took a run, and this filling defect was not in the carotid. At which point I got a panicked phone call to come and treat this stroke. So Blaze and I are talking, PA arrest maybe 3 hours ago, you know, no imaging of the brain. I said, stroke alert, call vascular neurology, let's get some imaging. So on the second CTA, no clot in the carotid, and we've got an embolic occlusion of the MCA. Brain looked good, so we took the patient to, for thrombectomy. So here you can see passage of the walrus into the high cervical carotid. We do our angiogram, segmental filling defect in the middle cerebral artery, and on the lateral you can see this Y-shaped occlusion, embolus extending into the bifurcation. Here is the vector at the clot, wire being removed. The vector's at the clot, and our large bore catheter is being advanced to the side of the occlusion. And again, I use that same relay technique where I really don't, I place my initial aspiration catheter at the face of the clot, don't interact too much with the clot, go distally, fragment it, and pull back the clot that you've grabbed with your smaller aspiration catheter into your large bore catheter. Maintaining aspiration, right? Now using that as an anchor, you can see the high placement that's going to be achieved with the balloon guide catheter, right? It's going to be advanced to the, we're in the cavernous carotid, and this is a very routine maneuver for this guide catheter. So now we're inflating, getting flow arrest, and hopefully reversal of flow to engulf that clot. So under balloon guide aspiration, we now take our catheter, through the balloon guide catheter, and we do our run. And typically, I'm finding you're going to see very clean TICI-3 revascularization. Admittedly, easy case. This was soft clot, easy to suck out. But it was a good case and fresh just to highlight the technique of using balloon guide catheter. So this is really how I came to play around and move a little bit away from super large bore aspiration, is that about 20% of cases are going to be tandem lesions, right? And I've always been in treating tandem lesions, I've been a retrograde person, meaning brain first, then neck. And I always found it, frankly, irritating, especially if it's 2 in the morning and I'm prepping a filter device after I've cleaned out the brain to do a carotid stent. And just thought, well, yeah, there are newer versions of balloon guide catheters. Why not just use that for the case and just use my balloon guide with flow arrest, right? That was my logic. And so that's how I got exposed to using walrus and kind of making a bit of a migration. So patient comes in with carotid occlusion, densely calcified carotid bifurcation, common carotid artery and arch, and a right MCA occlusion. This was an occlusion that I couldn't daughter, meaning I could not advance my balloon guide over a selective catheter. So I was forced to do an angioplasty, and that allowed me to advance the balloon guide into the proximal internal carotid artery, where I actually inflated it and did some aspiration, got some gunk out, and then I did a run. And you can see there's still some significant residual thrombus in the internal carotid artery, and we've got our MCA occlusion. So did the usual technique, relay aspiration, using the large bore catheter, and again, under a balloon occlusion, it is lower down, and revascularized. The additional benefit of the balloon guide is that you can aspirate, right, under flow arrest, and you can see that there's further reduction of thrombus within this internal carotid artery, uncovered a high-grade stenotic lesion in the internal carotid artery, even after the angioplasty, and so stented that, but again, with the benefit of having proximal flow arrest with the balloon guide, and now we've got nice patency and a cleaned out carotid. So a lot of benefits in treating a tandem occlusion case that's also saving you time with the balloon guide. Dissection, another reason to have a tandem occlusion. So we could also again see the utility of walrus. Here we've got this flame-shaped tapered occlusion of the internal carotid artery. This patient had a tandem occlusion of the MCA here and here. So we've got 3 lesions to treat, and again, suspicious that there is a dissection. Here, the balloon is inflated, so it allows me to traverse this really tortuous dissected segment with protection from flow arrest. And here we can see that despite this tortuosity, we're getting into the MCA, but I like having that the balloon in the internal carotid artery to try and limit any fragmentation and embolus of clot. Again, relay aspiration, the large bore moving into the target with the smaller catheter, the vector in this case being pulled down. I think it was a vector. And then we're removing our large bore from the occlusion site. And we've got revascularization of the MCA, but remember that distal tandem occlusion in the MCA? I've got to chase this. And this is where I like having the vector. If you've got distal occlusions, the vector is a long catheter, 160 centimeters. So other choices, you know, if I'm putting a 144 aspiration catheter through the Zoom 71 with a 2E, I'm not even going to get the nose of the catheter out of that. But if you've got a 160, it nicely matched with a good inner diameter, you know, it's a big straw and it's a long straw. You're going to get there. And that's why I like the Vector 76. So getting the Vector 76, we're done. Very clean revascularization. You can see the dilated dissected segment, but it's patent, no thrombus remaining. So no reason to, well, that would be just an awful place to stand. So I was very thankful to see that, you know, clean. We've got a revascularized MCA and our distal occlusion site as well. Something that's coming out now, just approved in the US, I haven't gotten my hands on it, but it's similar to the TENSing device. So it's this catheter insert called a cheetah that's going through a large bore 0.72-inch internal diameter aspiration catheter called Hippo, so some cute names. And it's all designed to be used with the walrus. So hopefully it works well, it looks promising, but if it doesn't, it's nice to be working with a walrus, a hippo, and a cheetah. So I'm kind of looking forward to giving this one a shot. Last case, 37-year-old obese female, acute onset of dysarthria, drooling, and right-sided weakness. We can see high cervical placement of the walrus balloon guide, angiographic run showing osteal occlusion of the left MCA, and really mature, robust collaterals. And this patient had dysarthria but no aphasia. Already my kind of spiny senses are kind of going off here. What am I dealing with? We can see the balloon guide is again driven high to that petrocavernous segment while we're aspirating. 2 thromboaspiration runs, and I really haven't achieved much at all. And again, highlighting, I'm not married to any technique. Yes, this talk's been on aspiration. If something's not moving, working well, I'm moving quickly to something else. Stent retriever deployed with you know, the Salumbra technique, stent retriever aspiration, and we've opened her up, really good distal flow, but there's just something funky about this lesion. It's irregular, still stenotic, and I'm just remembering kind of a clinical presentation, robust collaterals. So I'm not declaring victory, I'm hanging out, I'm doing delayed angiographic runs. Restenosis, we can see there's asymmetry now in the flow in the middle cerebral artery compared to the anterior cerebral distribution. So I've got an impending occlusion. Admittedly, many people in this audience are probably seeing this a lot more times than I am. But impending occlusion, so stented her and actually got a really nice result. She actually clinically did very, very well. And when I was done, we heard from her husband that she had had a stroke at, I think 7 years before this. So you're not the only country where actually a lot of these patients were in their 30s. I think at least 2 of these patients were in their 30s. So it seems like a kind of systemic global problem. I wonder if diet has anything to do with this. So, you know, I think the nice thing is that in the dining hall of neurointervention, we're just not having the same meal every day. I think that's a nice thing in our field. You know, for me, I like to get comfortable with something. I think we should all be comfortable with a mode, but I think maintain interest, always be ready to kind of surf new waves, see what's out there, so that ultimately we have a lot of choices so that we can individualize our care for the individual presentation of any specific patient. Thanks so much.